So the second question that I want to explore today, what is the pre-test probability that a person with upper respiratory tract infection symptoms has a viral infection or a bacterial infection? So this question is being asked, obviously, within the context of COVID-19 and the test in this case being whichever test you currently have available in order to test for COVID-19. But I'd like to talk a little bit more widely around the probability of something being viral or bacterial and what that really means. What that means to you in terms of thinking about prescribing, what that means to the patient or parent that you're with, where you might be thinking about prescribing. So I guess the first thing that I'd want to just challenge there is, why are we even asking this question? Why does it matter whether today's infection, today's respiratory symptoms are due to a virus or a bacteria? Now that might seem slightly heretical for me to say something like that, but the reason that I'm talking about it is that some viruses cause very severe disease. Human immunodeficiency virus. Now we know COVID-19 and also influenza. So viral illness in itself is not necessarily a minor illness. Bacterial illnesses are illnesses that sometimes require antibacterials, but do they require them all of the time? Are we not able, with our immune systems, to fight off bacterial infections? Do bacterial infections not happen all the time without people coming to see a healthcare professional? So it's a little bit of a challenge to think about more than the binary situation of viral and bacterial, and think more completely about what the clinical presentation is, and then in terms of what might be causing it, what you might want to do about it in relation to the clinical presentation. So I've already talked about, when we've discussed the epidemiology of upper respiratory tract infections, that 80% of the time it's going to be caused by a virus. Now, that's quite an important figure, and it's very helpful to me as a healthcare professional when I've been having conversations about antibiotics with patients over the years. If I can help people to understand that antibacterials do not treat viruses, then it's quite logical, if 80% of the time that your symptoms will be caused by a virus, that I'm not going to need to give you an antibacterial most of the time. So that's actually quite helpful. There is a downside to that, which is that if I'm differentiating between the two with the patient, does it leave them with the impression that they have to have an antibacterial if there's a possibility that they're in the 20%? The answer to that question is that they don't, and therefore it requires an additional discussion about the patient's own ability to fight off infection themselves. In some ways, the COVID-19 era has given us a really good opportunity to show that a virus can be a serious disease, but only in a very small number of people. People are well aware now that deaths have been happening, people have been in intensive care units, people have been in hospital, but most people won't know anybody that's been in any of these situations, because for the most of us, more than 80% of us, it's a disease that causes minimal or no symptoms, or symptoms that allow us to manage ourselves at home. So there may be a better understanding in the population of what the significance of virus and bacteria is. So You're thinking about the assessment of the person presenting with respiratory symptoms consistent with possible infection. When you're deciding whether or not to give an antibiotic, you will be thinking about whether or not it's bacterial or viral, but you'll also be thinking of some other features as well. What is the risk of this progression to serious disease? So let's talk about somebody who may be at more risk of pneumonia. So this is somebody who is immunocompromised, has other long-term conditions, and of course is elderly, where pneumonia occurs most frequently. So certainly in the UK, we have guidelines that help us to differentiate between older people and very older people in our decision making about whether or not to give an antibacterial if we think there's a possibility of pneumonia. How long have they had it? How quickly do your patients come to you with respiratory infection symptoms in the hope of an antibiotic? Is it 1 day, 2 days? Is it immediate? Do they leave it longer? What feels like an acceptable length of time for you in order to make the decision? What is their current health status? Do they have underlying conditions? I've already mentioned age, but of course diabetes is one area where people will be at more risk of developing an infection. The capacity to return for help if the status changes. You will have patients who are cognitively able, who have families, who have people that are looking out for them. So you can hold off an antibiotic for a day or two to see what happens, because you know that they or somebody in their family will do something about it. If it's somebody who is cognitively impaired, living alone, your decision is going to be quite different. So what I'm trying to create here is a sense that there's lots of different levels of data that we need to consider before giving the antibiotic. Does it seem viral? Does it seem bacterial? Is this very early on in the condition? Has it been some time? Is this the sort of person that's going to get sick or the sort of person that's going to recover? This kind of decision making has been explored in a lot of different countries over the last decade. You will hear in this program about the Choosing Wisely campaign. In Canada, Australia, and the USA, this program has used the problem of antibacterial resistance, the overuse of antibacterials, as part of its Choosing Wisely campaign, and has had success. In the United Kingdom, our National Institute for Clinical and Care Excellence, our Public Health England department, and the National Health Service in England have all together, as a whole system approach, started to attack the problem of overprescribing for antibacterials for many years. And this is the sort of data decision-making support that we've been receiving in our countries over recent years. And it's the sort of thing that will help you to change the practice that I think that we need to do.